Hello, I'm Paul Walker, a medical oncologist with Circular Gene. I would like to welcome you and present another case in our ongoing Circular Gene Molecular Tumor Board series. This is a 61-year-old male who presented with bony and adrenal metastatic TTF1 positive lung adenocarcinoma. A liquid biopsy was drawn at the time of the tissue diagnosis such that the molecular tumor biology was known at the Multidisciplinary Thoracic Tumor Board discussion. Two important findings from the liquid biopsy. Number one, the cell-free RNA PD-L1 expression was very high, greater than 50%. And number two, there was an ARID1A mutation, which has significant therapeutic impact. In non-small cell lung cancer, 20% of the time, there will be an SWI-SNF chromatin complex mutation. SMARCA4 is one and is a distinct subset in non-small cell lung cancer now. The other one is the ARID1A mutations. An ARID1A mutation does promote immune therapy benefit. There will be an increased mutation load, there will be an increased tumor infiltrating lymphocytes, and there frequently will be elevated PD-L1 expression. This is a study from University of California at San Diego looking at ARID1A alterations as a biomarker for longer progression-free survival on those being treated with immune checkpoint inhibitor therapy. And they really identified several cancers that had a rather high incidence of ARID1 mutations. Leading the list was endometrial cancer at 49% of the time, second gastroesophageal 20%, cholangio 20%, bladder 17%, and in non-small cell lung cancer 5 to 6% of the time there was an ARID1A mutation. Another very important and impactful finding with ARID1 mutations is the association with microsatellite instability high. In general, MSI high was present in 20% of the patients that had an ARID1A mutation as opposed to 0.9% in those that were ARID1A wild type. And even if you look at non-small cell lung cancer, 5.9% of the patients with metastatic non-small cell lung cancer with an ARID1A mutation did also demonstrate microsatellite instability high, further impacting an immune therapy benefit. These are Kaplan-Meier progression-free survival curves in this population. On the A panel, this is all comers, and if there was an ARID1A mutation, there was a much better benefit with immune checkpoint inhibitor therapy as opposed to wild type. Panel B is excluding the MSI high patients, just looking at the microsatellite stable patients, and even those patients treated with immune checkpoint inhibitor therapy had a much better progression-free survival compared to ARID1A wild type patients. This led our Thoracic Multidisciplinary Tumor Board to render several treatment recommendations. First and foremost is immune checkpoint inhibitor is the foundation of treating this patient. Whether IO alone, given the high plasma cell-free RNA PD-L1 expression, or chemo IO, then followed by ongoing immune checkpoint inhibitor therapy. We also discussed and recommended an early repeat plasma NGS at the 6 to 9 week mark to assess a response demonstrated by clearance of the ctDNA. Those patients who will clear ctDNA by 6 to 9 weeks have much better durability with immune checkpoint inhibitors compared to those that don't. And certainly, if there's a prolonged benefit with complete response and a decision regarding IO discontinuation is discussed, then repeating the plasma NGS can also be helpful, as the data demonstrates in that setting. If there's complete clearance at the ctDNA after prolonged IO therapy and a CR, 93% of the time it will be durable. And finally, a discussion is always made. It is important to repeat a plasma NGS upon any clinical or radiographic disease progression to determine the subclonal driver, new oncogenic drivers, and potential resistant pathways. I hope this was helpful to get a better understanding and grasp of the impact, even though not targetable, but actionable with an ARID1A mutation. Thank you.